name is Dr. David Oladele. I'm a Chief Research Fellow and also a consultant clinical physician at the Clinical Science Department of Nigerian Institute of Medical Research here in Lagos. I'm also the head of the department of that department in NIMR. Nice to meet you. Yes, the research is tied to integration of hypertension management into HIV clinic using tax strategy in Lagos, Nigeria. A research was sponsored by the National Heart, Lung and Blood Institute of the National Institute of Health, NIH in the US. It's a collaboration between three institutions: Nigerian Institute of Medical Research here in Nigeria, St. Louis University in Missouri, and the University of America, and also New York University at London. It has three PIs, principal investigators, which include Professor Oladele here in Nigeria, Professor Olugbenga Ogedegbe, New York University, and Professor Juliet Iweromo from St. Louis University. The program or the research work is actually meant to address the challenge of providing care for hypertension among patients who are diagnosed and live with HIV. We know that with the access or improved access to antiretroviral medication, persons infected with HIV are now living longer compared to before. And a lot of them are now developing non-communicable diseases, of which hypertension is a major risk factor to cardiovascular disease, stroke, and all the rest. So the best way to now prolong their life and their quality of life is to find a way to integrate the treatment for hypertension into HIV clinic. Because the current picture we have in Nigeria is patients go into the clinic, they get the care for hypertension at a different place compared to where they get HIV treatment. So the idea is to see how we can actually bring the treatment for hypertension and HIV together at the same spot and screen for hypertension actively among patients who are HIV positive, so we can diagnose them and take care of them on time. The prevalence of hypertension among persons with HIV varies across the world. Different studies, meaning that research work done from different settings, have reported different prevalences. It has ranged from like 14.something% to like 16%. But a study among HIV population in Nigeria, Southern Nigeria, reported about 25% prevalence in recent one. So we can say conservatively the hypertension prevalence among those who are living with HIV is between say 15% to 25%, depending on the settings and the age of this patient. Yes, thank you very much. I actually was mentioning that earlier on. HIV is an infectious disease, meaning that when the patient has HIV, we know how it affects the immune system. And if it is not taken care of, it can lead to what we call opportunistic infection, and the patient can die without treatment. But thankfully, because of the access to HIV that was brought about by the PEPFAR funding from the year 2004 to date, a lot of patients who are HIV positive have access to HIV treatment. But in Nigeria, we've had a situation in which now we have been able to decentralize HIV care. At the onset, in 2002, when we started HIV care in Nigeria, you can only get treatment in 3 centers. Here at Nigerian Institute of Medical Research, at Military Hospital in Yaba, and also at Luth in the Diaraba. But over time, every major comprehensive primary care center that have capacity to do to treat diseases now have HIV treatment center. And Lagos has have well over 60 centers like that. So with that improved access via decentralization and improved access to drug and commodity, most of the patients now are living longer and more productive life. So the common cause of death among HIV patients before are the comorbidities. They are the opportunistic infection like tuberculosis and all that. But with improved access to HIV care, which are led to improve immunity, many of them are now manifesting what is common in the general population, that is increase in non-communicable disease called NCDs. So because of that, if we don't address the issue of NCD among hypertension, among patients that are HIV positive, the gain that we've had over time with regard to HIV treatment is likely to be reversed. Okay? And a key among the non-contributing STDs is hypertension. So what we need to do is to be able to make a diagnosis or a screening for hypertension among patients who are HIV positive, and also be able to treat them so that you control the blood pressure. Therefore, they are not developing diseases that can lead to death because of hypertension, like cardiovascular disease, stroke, and all the rest. So that is why it is very important to address the burden of hypertension among patients who are HIV positive, because we are trying to kind of prolong their life, improve their quality of life, and at the end of the day, improve the outcome of their treatment for HIV. So the care for hypertension is very, very important in and among patients who are living with HIV. Now, TASSH in the service is something different from what we're used to. Now, what we're doing is to actually see how we can integrate care for HIV and for hepatitis HIV clinic using the task screening strategy. Now, what is task screening strategy? Task screening strategy is an offshoot of task shifting strategy. So, task shifting itself is, as WHO defined it, it's actually kind of decentralizing treatment from a highly specialized or highly skilled healthcare worker to those who don't have that skill. And it is meant to address the challenge of human resources for health. In other words, we know currently in Nigeria you have brain drain, a lot of doctors are leaving, nurses are immigrating. So you have fewer healthcare workers to address the large population. So using an approach to allow nurses or community health officers to make a diagnosis by screening patients for hypertension, and also counsel them on lifestyle changes, institute treatment, and refer the severe cases and comorbidity to doctors is what the program is all about. And the program itself is a cluster randomized trial, meaning that we are working in different primary care centers in Lagos. We're actually working in 30 primary care centers in Lagos. 15 of them will be randomized to receive the intervention. 15 will receive the standard of care. So what we're trying to do is at the end of 12 months compare the outcome of treatment for hypertension among those that will receive the intervention and those who receive normal care. And the intervention in this sense is actually what we call the practice facilitation strategy, meaning that nurses and CHO working at the 15 of the PAC receiving intervention receive additional support from a senior healthcare worker who will remind them of when to screen patients, how to counsel on the lifestyle changes and dietary counseling, and using the 5A, assess, and all the rest. And now we compare the effect of that practice facilitation, like a coaching strategy, in those 15 PAC compared to the other 15 PAC at the end of 1 year, looking at the change in the mean systolic blood pressure. So what we have learned so far is that for this program to work, there's a need for intense collaboration between the researcher and also the health system in the state. Currently, the institute is collaborating actively with the primary care board in Lagos State, as well as Lagos State AIDS Control Agency, to identify the centers and to train healthcare workers working at these PACs at different times, both baseline and other training, and to be able to now give them the skill to make the diagnosis of hypertension and also kind of monitor patient on treatment and refer the severe cases to doctor. The project kind of donates all the equipment needed for this screening to these centers through the PAC board. So what we have learned is that for this task-shifting strategy to be implemented and be sustainable in Lagos, there's a need for active collaboration between the researchers and the health system, in this instance the PAC board, and doctors and nurses working at the PACs. The other thing we've seen is, like I mentioned earlier, the challenge or the fact that we have a lot of attrition of healthcare workers. So, and then we have fewer doctors, fewer nurses, CHO to address the teeming need of patients. The challenge with the healthcare worker to be able to create enough time to attend to this patient because of work overload. All right, and work overload is not what anybody can do, so we can't just go ahead and begin to employ. Right, so what advice and what we've done is to see how they can actually kind of track their patient, kind of prioritize their patient to know when and how to address this challenge, and so that they are not overburdening care for the patient, but at the same time still giving quality of care. So generally, the approach has shown to us, and also to the Lagos State Health Management, that there's a need to be able to bring care of hypertension into the HIV clinic, so you are able to address the double burden of both the infectious and non-communicable diseases. And we hope that if this is done adequately, their quality of life will be improved and the health outcome will be improved in the long run. Yeah, thank you. Well, like I mentioned, the TASSH project is a collaborative effort between 3 institutions. That's the Nigeria Medical Research in Lagos, New York University, the US, and also in Louis University. The grant was awarded to the 3 institutions, and we have a team working on this project from the 3 institutions. So what that has brought to bear is a robust North-South collaboration on this project, meaning that experiences of the researcher working in New York and those working in St. Louis and they cross-fertilize with those of Nigerian researcher to be able to implement this project in context of Nigerian situation, because Nigerian situation is very peculiar. Just to mention that this same project was created in Ghana before they came to Nigeria, but the Ghana terrain is entirely different from Nigeria terrain. The health system is different. So there's a need to domesticate the approach of the research to Nigeria context, and that is the lesson we have learned, that there's a need for that collaboration, and it has actually caused exposure to researcher here, to liaise with researchers outside the country in cross-fertilization of ideas and the best way to meet or to address every challenge that took place during the course of the project, and also to build capacity of the local researchers through exposure to education outside the country, PhD and all the rest. And one of us actually being funded for PhD on the TASSH grant in the US. So that is one thing that is going on. And I think what NIMR researcher can draw from there is that there's need for us to begin to have research in NIMR, collaboration with institutions outside the country, that will have elements of building capacity of local researchers. It could be through visiting scholars to whether UK or US, for them to gain new experiences, go to laboratory to learn new skill, or through advanced learning, a master's program, a PhD program, or a certificate program, through this North-South collaboration. So I think that is one thing that NIMR need to learn. I simply mean that we need to now broaden our horizon in building collaboration with institutions outside Nigeria, having this partnership, and building, also exploring how to improve the existing relationship we have with other institutions, so that NIMR in the long run will be able to build capacity of the researchers, especially the junior researchers or the early researchers in the institute, on how to improve their career, improve their skill, and also be internationally relevant when we work with this institution. Well, in my capacity as the chief research fellow, what I can do is to counsel with them and advise them, but I'm not sure I have any other thing to do to assist them, that will point them the right way and advise them on the best thing that can be done to improve access to improving their skill with regard to research, considering North-South collaboration. But generally, I would like to say to NIMR, young and upcoming researchers, to believe that there are possibilities everywhere. All right, so it's be a good time to go online, browse for possibilities, and never can tell. I was telling, this is my personal story. I was telling a young colleague yesterday who asked about the same question. I actually did a master in endoscopy and tropical medicine 2014 to 16. And how did I get that funding? I got the funding through the African Nagasaki scholarship. And the question, how did I get the scholarship? I was driving to work that fateful morning. My friend sent me a mail. Actually, he called me that day. I sent me a mail. Check it out. And I checked the mail. The mail was about the scholarship. And a wise friend, the older colleague, once told me that you don't lose anything by applying. You don't pay money to apply, just keep applying. So I applied for many positions. So I applied for this one, The first time I wasn't given, and I was asked to apply. I applied the next year course every year. The second year, I crossed the initial phase, got to the second phase, and I was told that my score is not good enough to be given master for, to be given MSc scholarship. But if I don't mind, I could take certificate course in clinical trial. And I said, okay, no, fine, I take certificate course. So when I was writing on certificate course, I now applied for funding to complete it to get the master's in clinical trial. And that I did, I got it, and it was through distance learning. And that's how I got that. It was fully funded master's. And so, but the advice is young researchers to open their eyes, open their mind, keep applying. You never can tell. One day, fortune can smile on you, and you get a fund and you move forward. All right, thank you.